So, one of the things I think most of us forget, Dr. Pinto really mentioned hydration. I think I try to teach even my fellows every day what is the EDP, and this is a very good study that came out, Poseidon study, and we should all be proud. Actually, the study was designed again by an Indian and done in the United States. And Poseidon study is very good, very effective in hydration, LVEDP based hydration, reduced contrast-induced nephropathy. Tremendous study, and I think we are not promoting that actually enough. Now, if EDP is less than 13, give about 5 ml per kilogram per hour, 1 hour before and 4 hours later. EDP between 13 to 18, give 3 ml. More than 18, give 1.5 ml per kilogram per hour. Anyhow, thank you very much for that comment on the hydration.
You know why it's not popularized?
Because it's nobody's
Nobody's benefited. So if you like, you know, this is how it works. The no industry promotes. The contrast industry promotes that, okay, you use this, your CAN is less, but you never taste. And we keep telling everybody, to all our juniors, it's a hydration, 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 hydration. You pump fluids, nothing will happen. They do extremely well.
Yeah.
I think this is a fantastic point Dr. Ramesh has brought out. LVDP, just put a pigtail in LV and just check the presence in plot. And most of our patients are well hydrated now.
Yeah, yeah.
We in fact push at 250 to 300 ml.
All right.
In fact, we tell our nurses, he's our guest, so make him bring 2-3 glasses of water.
Yeah.
As simple as that.
That's true. That's a very good comment. So I have no disclosures for this talk. And here's a 60-year-old man with hypertension, cardiac arrest at home, return of spontaneous circulation after 1 round of AP and CPR, pH is 7.2. As you can see, the EKG has ST elevations, but it's in AVR and V1. And many people actually ignore these two and forget that it is a ST elevation MI and may treat it as non-ST elevation MI. So unfortunately, that should not be done. As you also see that there's slightly widening of the QRS complex, the ST depressions. If you see this EKG, I will start actually running out of the house very quickly and get to the patient as soon as possible. I think, you know, if you mistake that EKG for something else, I mean, obviously, you may not want to do a cardiac cath, but I would definitely in that patient, even though pH is 7.2, you should do cardiac catheterization and start hypothermia. And also start all the medical therapy that is required. So this is, as you can see, it's a proximal LAD or ostial LAD or left main obstruction, along with a very small non-existent circumflex and RCA that has a significant lesion. So this is prior to disclosure, prior to culprit, okay, culprit shock trial. So now what? How should you treat this patient? I think all of the above is correct, depending upon your particular country and institution and what support devices you have and how much can the patient afford is always a difficult question. And in the United States, more than affordability, we also look at actually what is going to be the long-term outcome. Somebody we need to place on ECMO, it can be done, but you need to have a backup plan on ECMO. You know, so is it a VAD patient or not a VAD or a heart transplant patient? So this patient, as I said, that prior to culprit shock, we used to treat everything as in shock, and so this patient had a successful PCI of the proximal ostial LAD and left main and RCA with the impeller support. As you can also see, there's a right heart catheterization performed. A Swan-Ganz PA catheter is left in place. And follow-up, he remained hypotensive. The VA ECMO was placed, and as still, you know, that's the next step after impeller. And continued on high-dose dopamine, epi, norepi, amiodarone, as he was having more VFib. And the patient developed renal failure and remained acidotic and ischemic leg from the ECMO cannula, and transferred for heart transplant. And at the transplant center, he was re-evaluated and made comfort care, and he died 3 days after cardiac arrest. So think about it. You know, when we talk about cost, sometimes we think about all these things. And if a patient dies on impeller, the impeller is not paid by the government. It's not reimbursed. And so So you $25,000 that actually go for waste. 47-year-old female here, diabetic, antiphospholipid syndrome, and lupus anticoagulant with on rivaroxaban, and presented with anterolateral MI, loaded with ticagrelor in the emergency room. Primary angioplasty was performed, and LAD stent was done, and TIMI-3 flow was obtained, and a patient was transferred to ICU. 1 hour later, VFib arrest, refractory to DC shocks, ongoing CPR, and auto pulse, or we call it Lucas, was given at the same time, brought to the emergency cardiac cath. So as you can see, this picture tells you a lot. Obviously, there's no flow at all, and multiple shocks, and then VFib, agonal rhythm, asystole, auto pulse again was repositioned, and while doing that, ECMO was started. Patient was placed on ECMO immediately, and as you can see that stent was thrombosed, and LAD stent. You can see a lot of things here, that is under-deployed stent and undersized stent, and you can still see that it is not dilated even after the second and third picture that you can see. So there's probably some calcium in this patient, and that's probably the reason that it was not well dilated. So then poor flows on ECMO, reposition the cannula, and this patient compared to the first one, on day 1, no contractility. And by day 22, gradually patient improved, had initial shock liver, shock kidneys, and improved over time. Again, ischemic legs are very important in this patient, and this time it is in the balloon pump leg that the patient developed ischemia. And so complete neurological recovery was obtained, EF improved to 40%, did not need a ICD. So these two patients are slightly different, and you think about everybody can be checked a box for cardiogenic shock, but it is very difficult, and the SKY has made a lot of attempt and to identify these different types of shocks and staging of shock. And in the first one, patient falls under IMPRESS trial. That's a patient who had a cardiac arrest, a pH is 7.2 or low, and 20 minutes to ROSC, and so that's the IMPRESS trial. On the other hand, IABP Shock 2 trial enrolled patients who are acute MI and cardiogenic shock, and where the lactate is more than 2, but altered mental status or urine output is slightly less than 30 ml, and but both of them are meeting the criteria for cardiogenic shock. However, both the trials are negative, and we'll look at why they are negative. So number one size does not fit all, and lack of common language has impeded the advancement of research on optimal diagnosis and management of cardiogenic shock in the setting of acute myocardial infarction. So finally, with the SKY, after all of us, a couple of physicians met, and their staging of shock from A to E. A is at risk, that means anyone who had an acute MI or who may be having a non-STEMI and might progress to a cardiogenic shock. B is beginning, that means they started showing some mild hypoperfusion, and blood pressure is low 90s and or below 90. And classic is now they're requiring a press, single pressors, and D is more than 2 pressors, and extreme is cardiac arrest patients or going into cardiac arrest. So for any stage, you can have a modifier of cardiac arrest. A patient who is in B can also might have arrested and come back to B. So you can look up on the SKY journal that these are physical exam, biochemical markers, and hemodynamics. And I think hemodynamics are quite important. And how do you assess it? By placing a Swan-Ganz catheter in these patients for hemodynamics. So the staging, and till now we never had a data to support how does a patient in stage A will do compared to stage E. So now we have a data right in the middle in the number of devices versus number of drugs. The more dark blue they are, the higher the mortality is, and the higher the stage is, and the more the stage is, the higher the mortality. So that is very clearly defined that the C and D and E stage of shocks carry a mortality of about 10 all the way to 60%. So, whereas if you leave them in B and try to keep them in B, the mortality is much lower. So try to bring the patients to B or at the most a stage C. So how do you do that? The therapeutic goal of AMI in cardiogenic shock is stabilize the patient and reperfuse. So remember, stabilizing the patient is first, and minimize the stunning, and that is stop myocardial injury, restore normal myocardial metabolism, prevent reperfusion injury, and enhance myocyte recovery. So when I was a fellow, the stabilizing the patient is every patient that came with an acute MI, we put in a balloon pump, we put in a pacemaker, we intubated the patient if there's any doubt that they're not like moving around a little bit too much, or we want to unload, and one way of unloading the left ventricle is actually keeping them calm and on a ventilator. So till then we never touched the coronary artery. Now then after that everybody started racing towards door-to-door balloon time, and you will see billboards in the United States, door-to-balloon time 14 minutes, and I'm not joking. This has been on a billboard that I saw, okay? So then that race now has stopped, and we are going back to actually stabilizing the patient. Why? If you unload, this is a true patient that from Dr. Gibson, and so if you unload the left ventricle on the bottom line, and the blue is the mortality that, myocardial infarct size is about 20%. If you don't unload, and if you just go and open up the artery, and his myocardial infarction size in anterior wall MIs is 50%. So there is a clear benefit of unloading the left ventricle. And how do you decide who needs unloading is EDP, and if you want to be perfect, actually pulmonary artery catheter as well. So this has been looked down upon by critical care in their data sets, but now we are trying to promote it, and there is definitely a great push towards using Swan-Ganz catheter in these patients. So why is the load or elevated left ventricular end-diastolic pressure is bad? Here is the data that shows the higher the EDP, the greater the mortality. So if you want people to survive, if it is less than 15, they do much better than more than 24. Is balloon pump useless? So it is not useless. See, this is the data that came out. People who have been reperfused or stabilized immediately with a balloon pump and continued reperfusion have done much better than without a balloon pump and if you do a reperfusion. So there is strong evidence to it. Oh yeah, the data is old, but the timing of the device initiation is more important than whatnot. And the same thing has been shown with impeller. You put an impeller before PCI versus after PCI. After PCI, there is no value. So whether it is $800 balloon pump or a $25,000 impeller, they're too late. So if you want to do something, Start off with a balloon pump. Start way early in cardiogenic shock. Don't wait until they go to C or D staging. When should you start balloon pump? Start at B. As soon as you see that this patient might actually need a balloon pump, put it in. So don't hesitate. Culprit shock trial, Dr. Pinto covered it, so I'll very quickly say two things: that do only the culprit vessel in cardiogenic shock as well. And so the complete revascularization and the complete culprit shock trial both go hand in hand. There is actually increased need for renal replacement therapy and mortality higher at 30 days. At 1 year, the data is mortality, there is no difference, but heart failure rates and repeat revascularization was higher only in culprit vessel only, so I think culprit vessel should be treated first, and then you can stage the other ones. So that's because of that, the guidelines have moved to recommend what I showed in the first case. Do not do it. Do only the culprit vessel and bring them back for staged non-culprit PCI. So the 1 year all-cause mortality, as I said, it's still not statistically significant. And immediate multi-vessel PCI appears to be, the difference has attenuated compared to 30 days, but not significant clinically. 1 year repeat revascularization was higher, obviously. That this is no-brainer, right? We are all staging them and we are bringing them back anyway. So you will expect the culprit lesion only PCI to be having a higher repeat revascularization. So very quickly, I'll say National Cardiogenic Shock Initiative in the United States, we come up with our own algorithms at every institution, but at least about 18 centers initially joined the national CSI algorithm, and we say this is the recommendation: rapid identification of cardiogenic shock, cath lab activation, femoral access, and now we are becoming very bad in femoral access, so we have to retrain a lot of fellows and everybody. And once you confirm the cardiogenic shock, you have to decide on mechanical cardiac circulatory support based on left heart cath, right heart cath, and echocardiogram. The door to support time, this has to be shortened now to 30 minutes in any institution. So similar to door to needle time, the door to support time has to be shortened to less than 30 minutes. As part of the trial, we gave up to 90 minutes to do that, once you identify based on right heart cath, and whether cardiac power output can be calculated, and pulsatility index of pulmonary artery can be calculated, and based on that you can decide whether you need a right ventricular support or a left ventricular support. And so this is 1 year data of a National Cardiogenic Shock Initiative that has been shown that in all stages, the 1 year mortality is survival is about 53%, but whereas in C and D it is 62%, and survival in E is 31%. So stage E, when they come in that sort, maybe it is better to talk to the family, not to make them spend a lot of money on devices, so because the survival is very dismal in that group. So the several shock trials, and like a Danish-German trial, as compared to that, our national shock trial is increasing in numbers in enrollment, and the lactate and everything is, as you can see, but the 30-day survival is much better in this group of patients who are immediately given stabilization of their ventricles. So this is a 30-day survival, and from 2 days of cardiogenic shock trials, and in the National Cardiogenic Shock Initiative has definitely improved mortality. So this is a largest prospective North American cardiogenic shock study in past 2 decades, and it recruited the sickest cohort of patients in any major acute MI cardiogenic shock studies, including about 25% who were in stage E shock, who are unlikely to be recruited into any randomized controlled trials. Outcomes from the study are encouraging and numerically higher than any previous trial, most notably in patients with C and D stage of shock, with survival of 77% at 30 days. And we hypothesize that greater utilization of the protocol and more refined escalation strategies, including using of a right ventricle mechanical circulatory support, will lead to consistent survival rates of more than 80%. Patients unfortunately continue to have increased 1 year mortality, emphasizing the need to optimize guideline-directed medical therapy for heart failure, and probably novel therapies and heart transplants as well. And lastly, given the promising trials now, Recover 4 has started, and we have to wait for those results in the future. So in dealing with advanced cardiogenic shock patients in the current era of mechanical circulatory support, an appropriate device per patient selection algorithm should be applied to improve clinical outcomes and optimize utilization of resources available in your hospital and in your country. With that, I'll take a stop. Thank you very much.
Excellent talk, sir. In fact, it should have been half an hour talk, because you went through the slide. So much of information is there, and it was a fantastic talk, sir.
Thank you.